Hello, everyone. Thank you for joining us today. I'm Lori Smetanka, and I'm the Executive Director of the National Consumer Voice for Quality Long-Term Care. Welcome to our webinar series this afternoon, COVID-19 Advocating for Nursing Home Residents, sponsored by the Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition. This is the 7th in our webinar series on these topics. As you know, we've been holding these weekly programs in order to keep you updated on the latest information and guidance, as well as actions at the state and federal levels related to COVID-19 and its impact on residents of long-term care facilities. We had overwhelming response from those of you participating to continue these programs and have decided to keep them going through the month of June. Next slide, please, Libby. So we're happy to continue the programs today. Today we'll be talking about the latest guidance from CMS that was issued earlier this week that covers a number of things, including expanded surveys and enhanced enforcement of facilities with infection control deficiencies. We're also going to be reviewing the data that's been reported by nursing homes to CDC and CMS about COVID cases and deaths in facilities. The first batch of data that we have been waiting for was posted yesterday to the Nursing Home Compare website for the first time. So we'll be looking at that. And then at the end of the program, we'll have time for discussion and questions. Next slide. Our speakers today include Toby Edelman, Senior Policy Attorney with the Center for Medicare Advocacy, and Richard Mollett, Executive Director of the Long-Term Care Community Coalition. A reminder that today's webinar is being recorded. The recording and slides will be emailed out to participants early next week and will also be posted on the Consumer Voice website. Also on the website, you can find the recordings and slides from the previous webinars in this series. Today's slides can be downloaded from the chat box. There's a link there for you. And I'd like to ask you to put your questions for today in the Q&A box on your control panel and use the chat box for making comments and discussion among yourselves throughout the program. All lines are muted throughout the webinar today, and as I said earlier, we will get to as many questions at the end of the program as we can today. So with that, I'm going to turn it over to Toby to get us started on the program today.
Okay, Lori, thank you very much. What I want to talk about this afternoon is the new CMS guidance on surveys and enhanced enforcement. Next slide, please. This was published on CMS's website on June 1st. Let me see if I can get this out of the way. Okay, it's called COVID, about 19, that's a little typo, of course, survey activities, CARES Act funding, enhanced enforcement for infection control deficiencies, and quality improvement activities. So it's a pretty comprehensive survey and certification letter that came out Monday. Next slide, please. What we see as is sort of typical now for the federal government's implementation of its activities, there's a lot of discretion left to the state. So there will be some opportunities for state advocacy, and I hope I'll remember to mention them as we go along and as we go through this new survey and certification guidance. Next slide, please. As background, CMS said that it conducted focused infection control surveys in between March 23rd, 20 to now. And they have two different percentages. One point in the memo, it says 53% of facilities were surveyed. In another part, it says 54%. So somewhere around there. The state range was 11% of facilities up to 100%. We know from the March guidance, which has had its date changed. It was originally March 20th. Now, if you look at it, it's called March 23rd. This described targeted infection control surveys. Now, what we know is that CMS said to surveyors, do not go into a facility if there's insufficient personal protective equipment, but obtain information necessary remotely to the extent possible. I think we had assumed that, like all surveys, there would be on-site surveys, but I'm beginning to wonder if a lot of this was actually done remotely. And we'll see that when we talk about what the survey results were that got released yesterday. Next slide, please. Now, what the guidance says is by July 31st, so we're moving along, there's guidance for that date, states must conduct focused infection control surveys on site, and they're very clear about on site in 100% of the nursing facilities. So that's about half of them, if it's 53 to 54% that have already had on-site surveys, or if they haven't had, if they had remote surveys, they're going to have an on-site survey by July 31st. If the state does not conduct all of these surveys on site by July 31st, then they must submit a corrective action plan to CMS. They're given a 30-day grace period, so that's August 30th. But if they don't complete all of the surveys, 100% of all nursing homes by August 30th, then additional funding under the CARES Act may be reduced by up to 10%. So that's important. It's May. It's a threat, but it is not mandatory. So even if states don't conduct 100% of the surveys by August 30th, they may not have any funding withheld. It depends. It's discretionary to CMS. Next slide, please. So the CARES Act is one of the laws that Congress has passed so far. It's the Coronavirus Aid, Relief, and Economic Security Act. And what the press release accompanying this survey and certification letter says is that the CARES Act provides an additional $80 million for survey activities, and CMS plans on distributing that money to states based on these performance-based metrics. So states need to be doing the surveys, the infection control surveys on site that CMS says, or they may lose some of their additional funding under the CARES Act. Next slide, please. Then there are 3 additional types of surveys that CMS says states must conduct. By July 31st, in addition to the 100% infection control surveys in all facilities, states are also supposed to conduct surveys on site at any facilities that had a previous COVID-19 outbreak. And the memorandum describes what previous COVID-19 outbreak means. They say cumulative confirmed cases over bed capacity of 10% or more. So I was thinking about, what does this mean, bed capacity? I think the distinction is bed capacity as opposed to number of residents actually in the facility. So if we had a 100-bed facility, but only 60 residents were there at the time, or there now, when CMS is conducting a survey, if it's cumulative confirmed cases of the bed capacity, 10% of a 100-bed facility is 10 or more. If it were 10% of the number of residents in the facility, it would be 10% of 60, it would be 6. So talking about bed capacity means there has to be a higher number, a higher threshold of residents who have confirmed cases of COVID-19 in order to be considered a previous COVID-19 outbreak facility. We know that occupancy rates are low. They've been hovering around 80% as it is, and they're lower now with COVID-19. So this definition requires an analysis of the bed capacity. How many presumably how many certified beds does the facility have? So 10% of confirmed cases, 20% of the combination of confirmed and suspected cases, and any facility that had 10 or more deaths from COVID-19. Now, I assume that means confirmed COVID-19, and as we know, there are a lot of people that probably have COVID-19 in nursing homes, but it's not confirmed, they haven't been tested, and they may not have the symptoms that are considered typical for people with COVID-19, as in elevated temperatures, coughs, or other respiratory symptoms, but nevertheless, they may have COVID-19. So we know from a New England Journal of Medicine article in April 24th about the Kirkland facility. They tested everybody in that facility, and the majority of residents tested positive for COVID-19 had no symptoms. So we think there are probably a lot of people that have COVID-19, but it has not been confirmed. So if this is 10 or more deaths from COVID-19, and that means confirmed, we may still not be getting all of the facilities where residents have confirmed COVID-19. So this is the first category of additional surveys states are required to do, these previous COVID-19 outbreaks. Next slide, please. The second additional category of surveys by July 31st is that states are required to conduct on-site surveys within 3 to 5 days if there are 3 or more new COVID suspected and confirmed cases since the last weekly report by the facility to CDC. From May 8th, the interim final rule, facilities have been required to report a lot of information, COVID suspected, COVID confirmed, deaths, all kinds of information. If they have, and that's a weekly report, at least weekly, facilities can do it more frequently if they choose, but at least weekly. CMS is now saying if they have 3 or more new suspected and confirmed cases since the last report, the state has to conduct an on-site survey within 3 to 5 days, or if they get one confirmed resident case in a facility that had previously been COVID-free, then the state must conduct an on-site survey within 3 to 5 days. Next slide, please. And then there's a third category of surveys, and beginning in the next fiscal year, states are required to conduct these annual focused infection control surveys at 20% of facilities in their states. And it's state discretion how to do that, which ones to choose. Now, maybe that is one opportunity for advocacy to be working with states or requesting states to do infection control surveys in particular facilities. They have state discretion at this point to choose which ones to do. Next slide, please. What CMS says in this survey guidance on June 1st is that if the facility does not conduct any of these surveys or all of these surveys that are required, it may possibly forfeit up to 5% of its annual CARES Act allocation. Again, it's possible, it's permissive, it's not a mandatory penalty. So even though, well, there's been a lot of reporting that there's tremendous enhanced enforcement, not necessarily. This is a permissive penalty that CMS would, a financial penalty against states that are not conducting all the surveys that CMS says need to be conducted. Next slide, please, Libby. So states are allowed under the guidance to expand the type of surveys they are conducting. We know that since late March, CMS said we are discontinuing, suspending standard surveys, complaint surveys, unless there are complaints or facility reported incidents that are triaged as immediate jeopardy, or infection control surveys. I think last week we talked about the reopening guidance, and it's in phase 3 when we would see states resume normal survey activities. What CMS said on June 1st is that states, if they want, could expand the types of surveys they're doing even before phase 3. So they could start doing this anytime, even now. And the examples of what CMS says states might want to consider is complaints that they've received that are not immediate jeopardy, but they consider high severity, that they're concerned about. They said maybe states want to consider doing revisits at facilities that removed immediate jeopardy, but were still out of compliance at a lower level. And the third category is the special focus facilities, those 80-some facilities in the country that are determined by the federal and state governments cooperatively to be among the poorest quality facilities in the country, with a history, several-year history of very high level deficiencies. So really poor care over a long period of time. There are 80-some of those and over 400 candidates for that program. So CMS says to states, you may want to consider expanding surveys and going into those facilities now, even before we get to phase 3 in the reopening. Next slide, please. CMS also has some recommendations for states about the routine surveys they might want to consider doing, but it's what states should do. It's permissive, not mandatory. And this to me is another opportunity for some state advocacy, state level advocacy with your state survey agency. So CMS says if there's a problem of abuse and neglect, if you think there's a problem with infection control, if the facility has been violating transfer and discharge requirements, if there's not enough staff, or if there's a problem with competency of staff. Maybe that would be an example. And I would just say from last week, I think last week, we're very concerned about, with the waiver of the 75-hour training that CMS did early on. We know that American Healthcare Association came up with an 8-hour online training program that a number of states have now adopted and said that that's sufficient if facilities if the person can demonstrate that the person got through the 8-hour online training program, and I believe Leading Age has a 9-hour training program, then they can be temporary nurse aides. So if you're hearing problems about that, there's insufficient staffing or the aides are not competent, CMS says they still have to be competent if not going through 75-hour training. But if that's a concern, that could be a priority for more routine surveys at the state level. And then finally, CMS says if there are some specific quality of care issues like falls or pressure ulcers in a facility, maybe the state should consider doing surveys at a facility with those problems. Next slide, please. Next part discussed in this June memo is enhanced enforcement. I have to admit, it's a very confusing part of this memorandum to me. And I actually wrote to CMS Wednesday saying, I have to talk about this Friday. I want to make sure I'm accurate about it, that I'm saying what it actually says. And the answer was, we really don't have time to talk. So I will tell you what I think it says and what the words are, and then what I think it means. But it is pretty confusing. It's part of the survey and certification memo. It's the part that the trade press has been up in arms about, saying, oh my God, we're going to have $20,000 fines. They're hitting us when we're down. Isn't that unfair and horrible? I don't think that's what it says, as we'll discuss in a couple of minutes. So of course, what they're saying is that enforcement, what we're saying is that enforcement is based on citing deficiencies in the first place. So we know if there is no deficiency cited, then there's of course nothing to enforce. So we need to have deficiencies, and we had discussed last week situations in Kentucky and New York City where there seemed to be serious problems of COVID and no deficiencies in the infection control surveys. One example was New York City, an article by Susan Jaffe, a long-term healthcare journalist. She said in 25 facilities in New York City that had more than 600 deaths of residents, those 25 facilities alone had more than 600 residents die, there were no infection control deficiencies cited as a result of the infection control survey. So that is alarming, to put it mildly. What CMS also said when it was discussing enforced enhancement is that it was describing what they called low-level isolated infection control citations, and their examples were proper hand washing and use of personal protective equipment. So I would say these are not low-level. They might be isolated, probably not. They're certainly not low-level problems. Hand washing is the most essential and critical problem and the basic reason that infections spread. So it's troubling that CMS even said that in this part of the memorandum. Next slide, please. So then it described levels of enforcement that would be based on whether the facility had been cited before with an infection control deficiency, the level of noncompliance in the current survey, so where on the enforcement grid the deficiency is cited. Is it no harm, harm, or immediate jeopardy? And then finally, what is the scope of the deficiency? Is it isolated, pattern, or widespread? And those factors obviously would make sense. You would have more serious penalties for more widespread serious deficiencies. But now we'll get to the details, and this is where I'm sort of lost. Next slide, please. So the first category is a facility that is cited with non-compliance in this survey only. CMS says if it's cited with no harm, either isolated or pattern, D or E, the remedy is directed plan of correction, period. Now that's a remedy that CMS has had for a long time, and I don't think it likes to use it very much, but that's the remedy that CMS is saying now, directed plan of correction for isolated or pattern no harm levels of deficiency. If it's F, if it's widespread, then what's supposed to happen is denial of payment for new, directed plan of correction, and denial of payment for new admissions with 45 days to demonstrate compliance. Now that doesn't make a whole lot of sense to me, and I can't tell, and that was one of my questions that went unanswered, whether that means facilities are given 45 days to correct before the denial of payment for new admissions goes into effect. I think that's what it must mean, otherwise what would it mean at all? So it seems to be that even for a widespread infection control deficiency cited in the current survey, the remedy will be directed plan of correction, and if, I think this is what it means, if the facility does not correct the deficiency within 45 days, then there's denial of payment for new admissions. Next slide, please. The next category is a facility that's cited with a deficiency in the current survey now and once in the last year, either at the annual survey or at some other time. Had to be cited with an infection control deficiency now and once before in the calendar year, in the year. If it's D or E, so again, if it's isolated or pattern, no harm deficiency, there's a directed plan of correction, denial of payment for new admissions, again with 45 days to demonstrate compliance, and at CMS's discretion, a per instance civil money penalty of up to $5,000. So that would be the maximum, and it is permissive, not mandatory. So that would be the possible penalty, those three things, if the facility was cited with an infection control deficiency now and once before in the year. If it's widespread, then there's denial, directed plan of correction, denial of payment for new admissions with 45 days to demonstrate compliance, and a per instance civil money penalty of $10,000. Now it doesn't say here permissive, it says per instance. Maybe that means it's mandatory, not entirely clear. This language is very confusing in this part of the memorandum. Next slide, please. The third category is a facility cited with noncompliance in this survey and, in addition, 2 or more times in the previous year. So again, if it's isolated no harm in this survey, it's directed plan of correction, denial of payment for new admissions, and then with 30 days to demonstrate compliance. So that looks like a shorter correction period. And again, at CMS or state discretion, a per instance civil money penalty of up to $15,000. Then what it says, or per day CMP may be imposed as long as the total amount exceeds $15,000. That doesn't make any sense to me either. I think what they're saying is there could be a per day CMP, but not exceeding $15,000. But that's not what it actually says. It could be a per instance, a discretionary per instance CMP up to $15,000, or per day CMP that must exceed $15,000. Again, if it's a widespread deficiency this year and the facility had been cited twice or more in the previous year, directed plan of correction, denial of payment for new admissions with a 30 days to demonstrate compliance. And again, this language of a per instance CMP of $20,000 or per day CMP as long as it exceeds $20,000, which does not make sense. Next slide, please. The next category is a facility that is cited with a harm level deficiency in this survey. And what CMS says, we're not looking at facility history at this point. If there is a harm level infection control deficiency, there must be directed plan of correction, denial of payment for new admissions with 30 days to demonstrate compliance. And then it just refers to the CMP analytic tool. That's a tool that was implemented July 2017 that replaced what Obama had done in 2014. The Obama guidance was that the per day was the default civil money penalty. What CMS replaced it with in July 2017 was a default of a per instance CMP. So per instance CMPs are probably what will be done for a harm level deficiency. But the facility, and it's a complicated analytic tool. It goes through a lot of things. If the non-compliance began before the survey, it's a per instance. If it's cited at the survey, it could be a per day CMP, but not if it's an isolated instance of harm to a resident, or if there's the facility has a good history of compliance. So in essence, it's a per instance CMP for harm level deficiencies. This is not a change from current guidance. And what CMS had said is that they were trying to enhance enforcement for lower levels of noncompliance. The last category, next slide please, is a facility that is cited with an immediate jeopardy deficiency at the current survey in infection prevention and control. Again, CMS says we're not looking at facility history. If there's an immediate jeopardy infection control deficiency, what will happen is a directed plan of correction, denial of payment for new admissions with 15 days to correct, and a CMP according to that very confusing analytic tool that pretty much says per instance CMPs are what we're going to impose. In fact, the immediate jeopardy, CMS comes up with a new idea in that analytic tool. You know, ordinarily, immediate jeopardy doesn't have to have actual harm. You don't have to be injured or killed in order to have an immediate jeopardy deficiency. What CMS says in that analytic tool is that we're going to have different kinds of immediate jeopardy. If there was real harm to a resident, there's one category. If there wasn't any harm to anybody, that's a different category of immediate jeopardy. So I know this is confusing. I've read this a bunch of times since Monday and did try to confirm, but this is what I think they're saying is their enhanced enforcement going forward for infection control. Next slide, please. So we had expressed concern last week that facilities weren't cited with infection control deficiencies during these focused infection control surveys. I just mentioned in New York City, Kentucky, we discussed last week. The Louisville Courier-Journal had an analysis saying in 2019, 102 of 285 facilities, 36%, were cited with infection control deficiencies. Now, during this focused time, 154 of Kentucky's facilities had infection control surveys, but only 2 were cited with infection control deficiencies. If that same percentage had applied, 36%, we would have seen 55 facilities. They would have been cited with an infection control deficiency. So we were pretty alarmed last week and concerned about what was going on in the infection control deficiencies. And we got our answer yesterday. Next slide, please. What CMS released yesterday was data about the 5,743 infection control surveys that have been conducted during this focused survey period since late March. Of the 5,743 surveys, only 163 facilities, that's less than 3% of them, cited an infection control deficiency. There was 1 immediate jeopardy deficiency, 1 actual harm deficiency, and 161 no harm infection control deficiencies. These are the surveys that CMS has conducted. And we want to go back and we will try to do this to get a better analysis for next week of these surveys. But to find them, there are about 10 or 12 collections of survey reports. And I'm not sure if they're organized by state, by date. I don't know how they're organized. I'm going to try to find certainly the immediate jeopardy and the actual harm deficiencies, and at least some of these no harm deficiencies to see the kinds of things they were citing. So I think the big concern about this is that even though CMS says it's doing enhanced enforcement for infection control deficiencies, they're not citing any infection control deficiencies, or hardly citing any. Less than 3% is not an overwhelming number. And how we're getting no deficiencies when so many people are dying, when we know from the GAO report we talked about a couple of weeks ago, is like the #1 deficiency cited in nursing homes over the years. Widespread, pervasive, and pretty much unenforced. GAO said 82% of facilities between 2013 and 2017 were cited with infection control deficiencies at least once. 48% were cited multiple times. And yet suddenly, now that we have focused infection control deficiencies in the middle of the pandemic, less than 3% have been cited with deficiencies. So I find that very alarming, and we'll try to find out more about what happened in these infection control surveys. Why didn't they find anything? Were they on site? Were they remote? What was actually going on? Next slide, please. The very last part of this June 1st memorandum is discussion of the quality improvement organizations and what they can be doing with infection control. So the first thing is that the QIOs have started an 8-part weekly training series for nursing homes on infection control. Last week was the first one. I listened to a little bit of yesterday's pretty much rah-rah. We're doing a great job. Everybody's doing such a wonderful job in infection control. But they're doing an 8-part series to tell nursing homes, train them in how to do infection prevention and control. The QIOs are also working with about 6,000 small rural facilities. They provide technical assistance to 3,000 low-performing facilities that have what CMS calls infection control challenges. And the final thing that this is a possibility for state advocacy is that states may request assistance for facilities that have a COVID-19 outbreak. So if we know of facilities, if you know of facilities that are really having serious challenges, trying to get the state to get the quality improvement organization, somebody in to try to figure out what is going on with the facility, how can they do a better job. Next slide, please. I think we are ready for Richard to talk about the data. Thanks very much, Richard. Turning it over to you.
Thanks, Toby. That was just so interesting, and there are just so many issues going on. It is really complex, but I personally appreciated your explanation. I just had one quick question, actually, before I start for you, if I may, is the trainings, to the extent that you listen to the QIO trainings for the nursing homes, were they substantive? I'm just personally very confused as to why we see the hand washing issues as you discussed here, and we've all discussed the past several weeks.
Right.
It's really basic. What are they? Is there anything like special that they're training them on, or
anything new? No, I think it's how to do an infection control program. And the part I listened to, I got a call in the middle, so I got off the call. But it was, how people are being creative and they're doing such a good job. That's what it pretty much was. I wasn't hearing anything new, but I did get the slides, and maybe what I could do is circulate them. Since I've signed up for these, I'm able to get the slides. I can circulate them to Consumer Voice, and people can see what the QIOs are telling nursing homes to do in infection prevention and control. But there is nothing new here. That's what's so troubling. When I looked at those old infection control reports that CMS sent to Tony Chickatell at Canner, and I wrote the report about those 171 reports, CDC said, look, there is nothing new here for COVID than for any other infection. These are long-standing requirements. You must wash your hands. You must have and properly use personal protective equipment. You must disinfect equipment, medical equipment between residents. There's so many deficiencies, that I've seen in the past at least, where there's a glucometer and they go from resident to resident, but they don't clean it. They don't disinfect it properly. Facilities must track and isolate infections in the facilities. That's what they're required to do. It's nothing new under COVID, and yet it doesn't happen. It doesn't happen.
Thank you. It's so disturbing, and that's why I just wanted to clarify too, because I'm not a clinician, but I wanted to make sure and to reiterate that for everyone on the line. So thank you again, Toby. So I'm Richard Mollett with the Long-Term Care Community Coalition, and I'm going to talk about some of the new data that came out this week on nursing homes and COVID-19. Next slide, please. So first I wanted to do just a quick review. I've talked about this on a couple of earlier programs, but I just wanted to mention again, and I also know that there's still some confusion about this. We get questions about, and not only questions, but also concerns about this from family members and from ombudsmen. As of May 8th of this year, a couple of weeks ago, nursing homes have been required to inform residents, resident representatives, and their families of those residing in, families of those residing, in facilities by 5 p.m. the next calendar day following the occurrence of either one of the following: a single confirmed infection of COVID-19 in the facility, or 3 or more residents or staff with new onset of respiratory symptoms occurring within 72 hours of each other. Importantly, because one of the biggest concerns that I've been hearing personally about is that the facilities are now doing, phone calls, or they're doing, email blasts, etc., for families and representatives. However, they're not telling residents. So this is very clear that residents must be told. It's residents' lives and it's residents' home. And it's just, to me, so indicative of the lack of respect and of understanding of who the residents are, and that the facilities are actually dealing with human beings when we hear reports like this. Importantly, this information cannot include any personally identifiable information, but even more important is that it must include information on mitigating actions that the facility has implemented to prevent or reduce the risk of transmission, including if normal operations of the facility will be altered. And I've been on some calls that providers have with their families, et cetera, and I rarely hear anything like that. Of course, I'm not on even a small percentage of the calls nationwide, but I'm not hearing that going on. And I think that's really important. Those are questions that the ombudsman and families and those working with families and residents can certainly ask. And of course, residents as well, as I said before, can ask as well and should be told. It must also include any cumulative updates for residents and their representatives and families, at least weekly or by 5 p.m. on the next calendar day following the occurrence of either a confirmed infection of COVID-19 or whenever 3 or more residents or staff with new onset of respiratory symptoms occur within 72 hours of each other. One note, as Toby mentioned before also, a lot of older adults, nursing home residents, don't display respiratory symptoms. So this is far from perfect, but it is something, and we would like to make sure that these things minimally are implemented for residents. So as I've seen noted a couple of times on the chat, the Consumer Voice has posted this. I think we all have materials about this as well, but you can easily just print this out and have it for yourselves. And if you're doing remote conversations with residents or with family members or both, that's great. Lastly, the last bullet here is reporting to the CVS that as of May 8th, nursing homes have been required to collect and report a range of data related to COVID-19 in their facilities to the CDC. The CDC is the Centers for Disease Control and Prevention, as opposed to CMS, the Centers for Medicare and Medicaid Services. Next slide, please. So this is what came out as of June 1st, which was just this Monday. CMS issued state-level information to the public on a range of different criteria. And this is, again, just for the state. So you can see here, there's, for each state, there's the total number of nursing home resident cases, nursing home resident COVID-19 cases per 1,000 nursing home residents. So that gives you an idea of the extent to which the COVID-19 has infiltrated facilities in the state. Nursing home resident COVID-19 deaths per 1,000 nursing home residents, total nursing home staff cases, total nursing home staff cases per 1,000 nursing home residents. Again, I think that this is really useful and valuable information for people to see what's going on in their community. As we've been talking in these programs in respect to state advocacy, this is all very useful information, or could be useful information, I should say, in respect to advocating on a state level. And then, of course, other information, nursing home staff deaths per 1,000 residents, total nursing home surveys that have gone on in the state, and the percentage of nursing homes that have been surveyed by the state. Next slide, please. As of June 4th, yesterday, CMS started reporting facility level information to the public. So on Monday, they reported that state level information, but we didn't know what was going on in facilities. When CMS first asked or demanded, excuse me, that nursing homes report to the CDC, they said that by the end of May, they would in turn report that information to the public. It took them a little bit, but as of yesterday and on a weekly basis, they're going to be reporting facility level information to the public. However, these caveats are pretty much taken directly from the CMS release, but they're really important. As CMS notes, these are preliminary data and they may be subject to fluctuations as facilities are given the opportunity to both submit additional data and correct their data. The first deadline for reporting was 2 Sundays ago, May 17th. CMS notes as the number of facilities reporting increases each week, it will increase the reported number of COVID-19 cases, suspected cases, and deaths each week. So it's a cumulative effect. However, this is really important, CMS notes facilities may opt to report cumulative data on their first collection date retrospectively to January 1st, 2020. And that poses a real problem for us to use these data and to understand what, if any, implications they have. Because in short, you could have nursing homes, what CMS did, excuse me, is CMS said that you have to do this reporting. The rule went into effect May 8th. However, it was optional whether you wanted to report earlier. CMS said when we were, us Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, California Advocates for Nursing Home Reform, when we spoke with them about this, they said, well, they could not impose a rule retroactively on nursing homes. And I personally think that that is an extremely narrow interpretation of CMS's authority. And the reason why I say that is because I understand, and I want to convey to you all, we understand that nursing homes couldn't say, well, actually, we want you to be doing X, Y, and Z for your residents with dementia every week. And that should have started 2 months ago, and now we're going to penalize you for not having done that. That is a practice change, and it would make sense that a practice change cannot be retrospective. However, when we're talking about just in the recent past and the collection and publication of data that is truly critical to the lives and well-beings of residents, for us knowing what has transpired over the last several months, and to be able to take the steps appropriate should we ever face a second wave or a continued wave in the nursing home world in the months and perhaps years to come. That information, as far as I'm concerned, is absolutely essential. So to get back to this third or fourth paragraph here, instead, what CMS has said again is that they're not going to ask facilities to report, but facilities can report. And that means that all the data, both the state data that I mentioned a couple slides ago, and this facility level data is much, much, much less useful because we don't know to what extent they may be reporting earlier. And if one facility is reporting more of its cases earlier and others are not, then how do we know? How can we ever make a comparison or an assessment of what's going on to say, well, these kind of facilities had more cases, these are the kind of facilities don't, maybe depending upon staffing, maybe depending upon whether they're for-profit or not for-profit, et cetera. How can we ever begin to understand what has gone on and what the indicators are of good or poor care or safety in respect to COVID if we don't have good, consistent data across the line as best as possible? No data are perfect, but these are almost purposefully imperfect. And that is a really serious problem. So as CMS notes here, and before I move on, they do feel like this will flesh out a little bit over the next couple of weeks. So hopefully, and I think we'll certainly be addressing this in future programs as more data are reported and as we're able to confidently look at and assess what is valuable and bring that back to you. I hope that'll be the case, but in any case, excuse me, there's going to be, and there are, I think, serious deficiencies unless somehow we're able to get CMS to require that reporting. Next slide, please. So I want to show you some of the examples of what they are reporting. So it comes in a large database. It's actually, pretty enormous. What we did, as those of you who are familiar with our work at LTCCC, is that we broke it down and we put it into files that are more user-friendly for people. So this is at our website, nursingHome411.org. We always give a citation to the original data, so you can, of course, look at the original data. But what we try to do, and what we'll continue to do here as the data become more robust, hopefully, is to drill down to just give you the information that we think is most valuable. But as you can see here, for the first column is the week reporting. So that gives you, and will give us cumulative information about what weeks the facilities are reporting, the name of the facility's address, the facility's city, state, and zip code. And then just before I move on column G here is whether or not they submitted data. And that's really important. So it's simple yes or no. So you can actually see whether your facility or facilities in your city or state have submitted data or not. And if they have, then you can look and see what that information is. Next slide, please. So this is what the reported data include. It's not everything. I just wanted to really summarize, but you can see it's a lot. Again, week of reporting, facility name, state, city, zip code, whether or not submitted data, and then some of the substantive data that's being provided by nursing homes is resident weekly admissions, both COVID admissions and total admissions, resident weekly and total confirmed COVID cases, resident weekly and total suspected COVID cases, residents weekly and total COVID deaths, residents weekly and total all deaths. And that's really, to me, really important because I have been extremely concerned for several months now that there are, at least since mid-March, that there are more people, frankly, that we're hearing about who are suffering from very serious neglect, including malnourishment, dehydration, increase in pressure ulcers and falls as a result of not getting even the most essential basic care that they need. And so a big concern for me is not COVID directly, but that this has been, frankly, unfortunately, a situation, in some ways an opportunity for facilities to provide less staff. Sometimes, it was, they couldn't help it if they were hit by COVID or their staff was hit by COVID and the staff called out. But in the nursing home world, that shouldn't be an ongoing week after week, month after month situation. Nursing homes should either immediately be getting the staff that they need or making sure that their residents are brought to safety in perhaps another location. In any case, moving on, they did include the residents' access to testing, also information just like for residents, for staff in terms of weekly and total confirmed cases, suspected cases, staff deaths, staffing shortages. Now, importantly, this is as identified by the provider. So simply what they're asked is, are they experiencing staffing shortages? And that is, again, I just want to be clear, entirely self-reported. So it's a self-determination. It'll be interesting to see what those data, look like, especially in the weeks to come. Last two items I just wanted to mention, and there's a lot of specific categories here that we did include in this initial data file that we posted. I'm not sure if we need to include it in the future, but it shows PPE, excuse me. So it shows the PPE supplies from ventilators to masks to gowns, how long the supplies are for, et cetera. And then lastly, they also have, as I spoke about before in the state file, we'll now see on the individual level, residents with new confirmed COVID cases per 1,000 residents and residents with new suspected or confirmed COVID who died in the facility per 1,000 residents. So of course, if your facility, say, had 10 deaths due to COVID and they're a 500 bed facility, it would be, I guess, 20 per 1,000. So it would be computed based upon a per 1,000 metric. Next slide, please. They did a nice job, actually. What I showed you before was how we clean this up, you know, the larger data table for our website and for future postings. But here you can see, actually, if you go to the data.cms.gov, and I have the whole URL here. I know it's pretty long, but you can either copy it or get it from the PDF file that the Consumer Voice is sharing. But they have a nice graphic of total resident cases. This is as of 5/31/20. So totally, there have been 95,515 confirmed COVID-19 cases, 58,288 suspected cases, and just under 32,000 COVID deaths. These data, as Toby has mentioned, as all of us have mentioned from time to time in the previous programs, are clearly underestimations. I think it goes without saying that a lot of facilities were not and are not reporting people who were their residents, but who were sent out to die in a hospital. And the reporting has been sketchy as well, including testing, of course, has been an issue. And then some providers did not want to divulge that they had deaths or cases of COVID-19 because they didn't want to get a bad reputation or damage their reputation, et cetera. So we've seen data from Kaiser Family Foundation, for instance, which shows significantly higher numbers last I checked. Next slide, please. I'm just going to go through again. This is so they had that nice, just blocks of information in the last slide. But here they have on the same page, this is all, the link that I have above here will be the same link going forward for the next couple of pages. I just want to quickly show these graphics. I think they did actually a really nice job. So you can see on the state level, this is the total residents confirmed COVID-19 cases and deaths by state. So that's this graphic, which is interactive. Next slide, please. And then you could also search for a nursing home. And there you can see all the nursing homes in the country. And you can, if you look on the left-hand side, the plus or minus, you can dig in. So if you're living in, say, the East Coast or the West Coast cities or Chicago area, et cetera, you can really dig down into what is going on in specific facilities, or there's a search function on the upper left-hand side. So I think they did an interesting job here, and this will be useful. Next slide, please. And what I did here is I actually, just using the country map, I clicked on a facility and you could see what information they provide. So this is Monaghan's, I'm hopefully pronouncing that correctly, Managed Care Center, gives the address, city, state, zip code, but also tells you the number of confirmed cases. This one, has 0, and the date for which that information is provided. So it's another way to, I think, for you, or if you're working with residents and families, to drill down to the information fairly easily and intuitively. Next slide, please. Just a couple of charts before I go on, and that they had. So this is, as I mentioned before, they're providing both on the state level and on the facility level, the resident cases and deaths per 1,000 residents. This is the data for that's reported as of May 31st, 20, according to CMS. Again, the same URL above, the data.cms.gov, et cetera. But you can see here the resident average cases per 1,000 residents. Again, this is it's a pretty chart, and I think but I have to say I'm not sure how useful it is, frankly. Just to be very clear, and again, because the range of reporting is so varied, both in terms of individual facilities actually identifying and reporting cases and deaths, period, and then even if even given the unevenness of that and the disparities there, is that some facilities are reporting historically back from January to May 31st, and others are just reporting as of May 8th. So how can you how can you depend upon that information? You really can't. So right now, from my perspective, the only thing that we have here is maybe some ability to ask questions and try to get some further information, not something that I would necessarily rely on and say, for instance, that, Massachusetts, which is the 3rd highest, is much worse than Vermont, which is way down here, or Maine, which was way down towards the 10th or 11th lowest. I don't think we can draw those conclusions. In fact, I would say confidently we cannot draw those conclusions. But I think that it's a way of starting to dig in and get some insights, and hopefully the data will improve a bit. And we'll certainly talk about that more in the future. Next slide, please. So this is the other chart that they also provide. Again, same website. This is the resident average deaths per 1,000 residents, excuse me. And again, the same thing. I would not use these data as being dispositive of anything. However, they may be a good source to start launching discussions with your state survey team, with your state legislators, but keeping in mind again that this is the proverbial tip of the iceberg, is that there's much more. This is really just, frankly, the very minimum that we know. There's clearly much more that has gone on that is either yet to be reported and in fact may never be reported. Next slide, please. So I'm going to wrap there. As I mentioned before, we have a coronavirus webpage, nursinghome411/coronavirus. We just posted the data to our data page. You can see it's the third tab over under the coronavirus. We're updating federal guidance as well. And we have resources, both ours and Consumer Voice and other resources that we think are useful. We are, pointing people in that direction as well. And hopefully, I think the purpose of that, obviously Consumer Voice is doing the same thing, as are other organizations, is that wherever you go, you can connect to the best information possible for what you need. Next slide, please. And I'm going to wrap it up there. Again, our homepage is nursinghome411.org. We have the coronavirus resources. We also have, I just wanted to mention, as I note here, fact sheets on nursing home resident rights and a lot of different data, as those of you who are familiar with our organization know, and Dementia Care Advocacy Toolkit. I think these things are so important. I've been thinking a lot, certainly throughout the pandemic, but especially over the last couple of months, that we really need to get back to, one, we need to get back into facilities, and we haven't talked about that today, something I'm sure that we'll be focusing on in the days and weeks to come, even more so, but that we need to know what our rights are, and families and residents and ombudsmen, need to know what their rights are and to advocate for them. And even though CMS has weakened some of the requirements, as Toby mentioned earlier, they've decreased the requirements for nurse aid training, at least temporarily, that most of the care standards, including dignity and treatment, including privacy, including the right to receive, to have sufficient staffing to meet your needs in terms of rehab and in terms of toileting, et cetera, those rules are all in place. And I am just frankly terrified that the states and the facilities themselves have thrown a lot of those out the window in the name of the COVID-19 pandemic. And that is, that's just not appropriate. It's certainly not fair. And it's hurting too many of our residents. So those tools are available as always, and they're as important now as ever. So thanks very much. And I'm going to hand it back to Lori.
Thanks so much, Toby and Richard, for your excellent presentations through what can be some complicated material, and also for your last comments, Richard, which are so important and something that I think we do all need to remember. We are hearing more and more, as Richard said, about many of the standards and regulations being essentially ignored, and we all do need to remember that they are, most of them are still in place, and we can continue to advocate for them. I know we're close to the top of the hour. Maybe we can just manage one or two questions. Before we get there, I just want to remind folks that all of the guidance and the materials that we've been talking about today are on multiple of our websites, and certainly on the Consumer Voice website on our COVID page. You can find all of the CMS information as well as summaries of all of it, so you can go there to download it. There were a number of questions again today about whether the information applies to other settings beyond nursing homes. Just as a reminder, the CMS guidance applies to nursing homes. They are the ones who regulate and oversee nursing homes through the Medicare and Medicaid programs, and that assisted living facilities, adult care homes, personal care homes are regulated by the state. The data that Richard was talking about, nursing homes are required to report it to the CDC, and then it goes to CMS for the posting, but assisted living facilities can choose to report the data, but it's not mandatory for them. So there may be some assisted living facilities that are reporting there. And as Richard said, when people can get back in to do visits, and particularly ombudsman programs and family members, is something that a lot of states and communities are talking about now. We talked about that a little bit last week with respect to what was released from CMS in terms of guidance. We will be talking about that in future weeks to come, because we know it's forefront on all of your minds. So let's just maybe take one or two questions as we end out today, and I'm going to ask Sam or Jocelyn to queue up a question.
Sure. Sorry, can you hear me?
Yes, go ahead, Jocelyn.
Okay, first I just want to thank you. I was actually going to ask about assisted living facilities, because we've had a lot of people bring that up, the fact that assisted living doesn't fall under CMS, so what can people be doing for people in those facilities? But the next question we were going to ask has to do with PPE, because the numbers of PPE are in the CMS data, and so a few people were asking about PPE, and is there at this point anyone responsible for ensuring that it's going to be available to nursing homes, especially as we move toward the fall and consider the possibility of other outbreaks?
That's a really good question. So I'll start, and then if other folks can jump in. As of right now, states and facilities have been left on their own to get PPE for their facilities. We know that that 2 one-week supplies are supposed to be sent from FEMA to every nursing home in the country. We know that those are still in process for being delivered, but generally the federal government has left it up to the states and the facilities themselves to get it. That's something that we think the federal government, well, from Consumer Voice's perspective, we think that the federal government should play a bigger role in securing that PPE for facilities and helping to get it to them. Anyone else want to make a comment on that?
No,
I agree with
completely.
you. Yeah, I do too. Thanks.
Okay, thanks. Next question.
Sure. So with all this data coming out, someone posed the point that it's really difficult to actually know the lack of care that's going on in these facilities because nobody besides staff has access to residents right now, including ombudsmen. And this goes towards some of the reopening conversations we had last week. But is there any idea of when in certain states ombudsmen may be allowed to visit facilities, or has there been any advocacy or movement around that?
There has been advocacy and movement in a number of states where they are developing some criteria for both ombudsmen to go back into facilities, as well as for families to have visits with their loved ones. A couple of states are starting to do outside visits. We've seen, like Massachusetts and Indiana, for example, and others are working on developing some criteria. So again, that is something that we will continue talking about over the next few weeks, but we know that ombudsman programs, state ombudsmen have been working diligently at the state level to talk with their departments of health and CDC and the partners at the state level about how to, and what the process will be for them to start doing in-person visits again. But be assured that ombudsman programs are, despite working virtually, they are still very actively working on behalf of residents and families, making phone calls, doing FaceTime visits, some of them doing window visits at facilities. So they are still working diligently on behalf of residents and families, and you should not hesitate to reach out to them if you have questions.
Lori, this is Robin. If I could just add just one short thing, that this is certainly an area for state advocacy. A lot of this is going to be determined at the state level, both ombudsman access as well as family visitation. So really encourage you to do what you can at that level.
Thanks, Robin. And let's do one more question.
Okay. Although it was answered, I think, in the questions, but I think there's a lot of questions about
Sam,
staffing.
it's kind of hard to hear you. You seem very far away.
Oh, I'm sorry. Can you hear me now?
You're still a little far away. Maybe just try one more time.
Is that better?
Yes, that's better. Thanks.
Okay. There was questions about the staffing levels. Who determines what is sufficient staffing, and how is that set if there are no standards?
Well, this is Robin. That is an excellent question. There is no definition, as we know, for the staffing levels. You know, in terms of what facilities are supposed to report, it just says, are there staffing shortages? And it's totally up to the facility to decide whether it's going to say yes or no. So this is something where there definitely needs to be clarity. Again, this can be something that you can raise in your state as a factor that should be considered, and you can push for it to be fleshed out and for it to be defined. But it's a big question mark.
Mm-hmm.
Mm-hmm. Lori, this is Toby. Can I just ask a question?
Sure.
The data that Richard, that got released yesterday, that facilities are reporting weekly to CDC. Am I correct that CMS says it will update that information in a couple of weeks and then weekly thereafter? Is that right? Or am I not
That's what
remembering?
I understood, Toby.
I thought it was weekly.
It's going to be weekly, but I think they gave themselves some wiggle room by saying it's going to be 2 weeks before the next time, and then after that it would be weekly. That's what I understood.
Oh, thank you.
I think that's right. So it's just gonna be updated, and presumably they will update the infection control survey since they're requiring 100%. So I mean, we will probably see more and different information at that point.
Right.
That's a
Okay.
good point about the surveys. Yeah.
Mm-hmm. And so we would encourage you also, many of your states are requiring reporting of information at the state level. So to encourage that continue at the state level, we know that many of the states have been posting the data on the Departments of Health websites or the governor's office's websites or some other venue. So please continue to request that information be posted so that you can be kept up to date on what's happening in your state.
Could I add one more thing about requesting while we're on things to request? I would actually encourage families and residents and ombudsmen in terms of particular facilities to push at the facility level for facilities to be sharing with families and residents the number of deaths in the facility as well. There's more, they are providing this information to CMS, to CDC. It is public. There's no reason why a facility can't share that information. It's just a lot easier for residents and families to be told by the facility rather than having to go to this database and make it available. So, and I think that's really important information for facilities and residents to have. So there's no reason facilities cannot share that information. So request.
Thank you, Robin. So thanks to all of you for joining us today, to Richard and Toby for digging into the CMS guidance and data this week and presenting on it. We appreciate the time you spent on doing that. And to Sam, Jocelyn, and Libby for helping with questions and the back end, and also to Robin and Eric for joining to help with questions today. We'll be back again next week. As a reminder, we have updated the Q&A on the Consumer Voice website based on questions that we're receiving. We're trying to review them and respond to the most frequently asked questions. We are reviewing the questions as we prepare the presentations for each week. So we'll look to address some of them as we best can in future webinars as well. Please continue to go to our websites for the latest information on all of the issues that we're talking about over these past couple of weeks. You can get, again, the previous recordings as well as slides from previous webinars on the Consumer Voice website on our COVID page, and there's a link right on the homepage to it. So thanks again. Have a good day and a good weekend, everyone, and we will talk to you next week. Closing out for today. Thanks.
Thanks, Lori.